Up next, we have Professor Jabbour, who is Vice Chair of Clinical Research and Faculty Development in Radiation Oncology and the Associate Director of Faculty Affairs at Rutgers University in New Jersey. I've had the pleasure to work with Dr. Jabbour on a number of occasions. She's an amazing speaker, and I hope you all enjoy this next talk.
Thank you, Dr. Spicer, and thank you to all of you for being here and for the invitation to this beautiful city and to be among esteemed colleagues. Today I'll be talking about how do we define high-risk clinical stage 1 when SBRT is the modality of choice. These are my disclosures. So today we'll appraise some patient features influencing the decision-making for SBRT. We'll evaluate clinical outcomes and toxicities for SBRT for central and ultracentral tumors and other risk factors for recurrence. And we'll study some biological features such as ctDNA that may help predict recurrence. And we'll review recent clinical trial data with checkpoint inhibitors. So quickly, just a case to kind of get us warmed up, and I will be looking for a show of hands. 66-year-old man with a 50-pack-year smoking history, using 3 liters of oxygen by nasal cannula at nighttime, who presents with a 1.5 centimeter right lower lobe adenocarcinoma, and EBUS is negative for mediastinal adenopathy. And you can see the tumor there on the PET scan. So by a show of hands, who would pick 54 gray and 3 fractions to treat this central tumor? 50 gray and 5 fractions. I'll go slower. 54 gray and 3 fractions. Any takers? 50 gray and 5 fractions. 60 gray and 8 fractions. 60 gray and 8 fractions. Any radiation oncologists other than Henning? Okay, 70 gray and 10 fractions. Okay, it's a quiet audience this morning. All right, I'll take it. So, I mean, I'm not really sure of the mix here, so I just introduced with this SBRT slide, which is the delivery of high doses of radiation to a small treatment volume. In the US, this is arbitrarily defined at 5 fractions or less, usually employing multiple beams, very highly focused, precise, et cetera. And just to assure everyone that we are talking about stage 1, these are all 4 centimeters or less, regardless of which edition we are talking about of the AJCC. And we know that these outcomes for local control are extremely high, at least at 3 years. In this slide, we see that they're in the upper 80 to 90% range of controlling the primary tumor, and the 3-year overall survivals are really limited by non-cancer-related deaths and poor medical operability. These are usually poor functional status patients. So this is the outline for the talk. We'll be talking about patient and tumor factors, comorbidities, recurrent disease, and histology as factors influencing our care of these patients, anatomic location, and finally some biological features as well as the trials at hand. So we know that there are multiple patient comorbidities, and this is taken from basically an anesthesia preoperative high-risk assessment. Things like diabetes, hypertension, BMI, alcohol dependence, et cetera, renal disease, and a history of cardiac disease that has sequelae. But there are also other softer factors such as decreased performance status, contraindications to anesthesia, or simultaneous cancers that may influence our choice to offer SBRT. We know that SBRT can actually be offered both in the recurrent setting after surgery and the recurrent setting after prior radiation. And in this review article, very nicely outlined kind of the outcomes. And we can see that while after surgical resection, the outcomes actually mirror sort of de novo SBRT for patients. After prior radiotherapy, things like prior radiation dose, as well as potentially more microscopic disease, may reduce some of the outcomes, both in terms of survival and the dose that we can administer affecting local control a little bit negatively. We know that squamous cell carcinoma is a well-established risk factor for local failure. So in this big review article from this large series from the Cleveland Clinic of over 740 patients, actually the main predictor in this multivariate analysis being 2.4 times higher for local recurrence was the risk was having a squamous cell carcinoma. So in my practice, I will usually try to dose escalate these tumors. Obviously, this is confounded because squamous cell carcinomas tend to be more central, which is a reason we limit dose to the tumor, so it can be sort of a little bit of a selection bias here, but this was sort of the main factor that came out of this article for risk of local failure. This is where the data gets exciting. We talk about anatomic location a lot in our field of radiation oncology, and this has a lot to do with very central tumors, meaning abutting the central bronchial tree and other critical structures. Robert Timmerman, who is kind of the founding father of American SBRT, initially conducted the phase 1 study at the University of Indiana and really defined this in his phase 1 study, showing that the tumors that were within this 2-centimeter dotted line centrally along the bronchial tree had higher risk of toxicity, and that these ultracentral tumors were later defined as directly abutting the proximal bronchial tree. So central tumors are really anything that can be abutting any of these important structures in addition to the trachea, esophagus, heart, brachial plexus, or major vessels. This brings us to RTOG 0813, which is really kind of one of the landmark studies in our field, looking at a dose escalation study of 10 to 12 gray times 5 fractions, and finding that 12 gray was safe with a very low risk of toxicity. But nevertheless, there were certainly some toxicities seen. There were 4 patients with grade 5 events, certainly as they reached the higher dose level arms at 11.5 gray, risk of esophageal ulcer, 2 bronchopulmonary hemorrhages, and 1 at the 12 gray times 5 level also. But you can see that this overall was a very well tolerated, as well as resulted in high rates of local control. The other trial that really guides our modern practice is the 8-fraction HILIS trial, the Nordic HILIS trial. This study, in contrast to RTOG 0813, was not quite as favorable in terms of its risk for patients. And here, patients experienced a 34% risk of grade 3 to 5 toxicity with 10 treatment-related deaths, and this was primarily bronchopulmonary hemorrhage. This is really because there was very poor control of how the dosing occurred in the central bronchial tree. So in group A, these are the tumors you see on the left in picture A. There were 8 deaths, 7 bleeding, and 1 pneumonitis, and this is really because the dose was really too high at the bronchus. And in group B, these were tumors that were further away, where there were 2 deaths. There was 1 esophageal fistula and 1 episode of bleeding. So 7 gray times 8 was felt to be safe and could be used for tumors that were further away, such as in group B, but should be used cautiously. And we have other solutions to this, but this trial also identified the fact that the bronchial tree, when given too high of a dose, particularly at the 0.2 cc dose level, was significant for bronchopulmonary hemorrhage. And these are some of the diagrams from the study that show us where these tumors were located. And you can see, obviously, they're quite central for those 10 episodes of death. In contrasting RTOG 0813 versus the HILIS trial, I think there are a couple of things to highlight that we do very differently in terms of caring for our patients. First of all, the prescription dose. I will highlight that in the HILIS trial, they really kind of elevated the radiation dose in the center of the tumor, whereas in more central tumors, it's probably more common to keep the dose more homogeneous to reduce kind of the hot dose that's given to the bronchus. Also, I will highlight in the HILIS trial that there were multiple histologies, including renal cell carcinomas, which can be obviously very prone to bleeding. Dose constraints to the proximal bronchial tree were very tight on RTOG 0813, which is really the preference in my practice to keep 4 cc's of the bronchial tree to less than or equal to 18 gray to the non-adjacent wall. And it was much more generous in terms of the HILIS trial in terms of dose. There were also much stricter doses for the great vessels. And also something that's very essential in radiation planning for SBRT is to make sure that the dose is actually very tightly formed to the tumor. And we call those conformity indices that we really try to obey in these situations. The Sunset trial was conducted here by our colleagues in Princess Margaret, and this shows that you can really dose paint, which means we can really limit the dose, as you see here in this diagram, to the esophagus, to the proximal bronchial tree. And by kind of minimizing the dose that's delivered there versus intensifying the dose to the primary tumor, the rates of toxicity were very low, where we also had very good rates of progression-free survival, local control, and overall survival. So common dose prescriptions for ultracentral tumors can be anywhere from 50 to 60 and 5 to 70 and 10, and so you can see those there. And in my practice, this is a diagram I created to kind of explain this to our dosimetrists. We really want to try to keep that dose off the non-adjacent wall and limit the dose to the center of the tumor and really kind of protecting part of the bronchial tree. Let's talk a little bit about biologic features such as ctDNA and genomics, as well as trials of checkpoint inhibitors. So we know that the patterns of failure after SBRT, while there are some local failures, they actually are relatively low, even as low as 5% in this series. But we can see that the distant failures are actually kind of a threat to patients. About in this series from the Netherlands, 15% of patients had distant failures, and most recurrences actually occur in the first 3 years. So important to think about. Also in RTOG 0236, one of our kind of seminal studies looking at SBRT, the 5-year disseminated recurrence risk for early stage tumors was about 20%, and for T2 tumors was 45%, higher risk in non-squamous tumors. So this really begged the question, is there a role for systemic therapies even in early stage disease, and leading to this question of high risk tumors. This is a small series out of Japan, looking at the use of proton beam SBRT, using passive scatter, kind of all a little bit contrary to each other, but in any case, they looked at 66 gray to 80 gray in 10 to 25 fractions, and they obtained 44 pretreatment samples of patients with non-squamous non-small cell lung cancer. And I'll draw your attention to, I don't know if this highlighter works, but the red, under the ctDNA diagram, you can see the red boxes, and those are the recurrences. Those are the positive ctDNAs, and you can see that that kind of correlates to the recurrences, which are in the pink boxes, right under the red boxes. And then additionally, some of the higher risk mutations like P53, EGFR, and KEAP1 are highlighted there. Now, this wasn't perfect. Obviously, there were other recurrences that were not detected by ctDNA, but the ctDNA positivity did predict for overall and event-free survival or progression-free survival. So this is something that can be potentially used. Some of the limitations of using ctDNA for smaller tumors are obviously that they may not shed as many cells, and this can be a limitation in the sensitivity of the ctDNA detection. We also have the MD Anderson series conducted by Joe Chang, published in The Lancet about 2 years ago, looking at the use of immunotherapy with SBRT, nivolumab for 4 cycles with SBRT, and giving 50 gray in 5 fractions or 70 gray in 10 fractions. And here there was a significant improvement in the hazard ratio, and you can see that the SBRT plus nivolumab reduced recurrence from 36 to 12%, and mortality was reduced. There was even a benefit in PD-L1 negative tumors, and our field was extremely excited about these superb data showing that we could potentially help high-risk patients, this impressive hazard ratio of under 0.5. But regrettably, we had other studies that have sort of come to fruition, such as Keynote 867. Similar study, this is 448 patients randomized to SBRT with pembrolizumab for 1 year versus SBRT alone. And these are patients even with performance status of 0 to 2 who could have declined surgery as well as being medically inoperable. Regrettably, the overall survival rates were not significantly different with the addition of pembrolizumab. However, and I will just also highlight that sort of the participants who had events were actually pretty high in the pembro plus SBRT arm with a hazard ratio of 1.33, actually speaking to sort of the medical issues that underlie a lot of the patients who go on to these treatments. Suggesting that there were other events that could have taken place in addition to just their cancer-related disease events. So here in the event-free survival, we can actually see there was a slight benefit to patients who are under 65 in terms of their event-free survival potentially being benefited with the addition of pembrolizumab, and similarly, some signal in overall survival as well. And here are the Kaplan-Meier curves suggesting potentially benefit to event-free survival and some potential overall survival benefit in this younger group of patients, also speaking to this risk of competing causes of death, such as other medical comorbidities, although this still needs further analysis. We also heard a few weeks ago at ASCO 2025 about the SWOG NRG S1914 study, also regrettably a disappointment for our field, with the addition of atezolizumab to SBRT in high-risk patients. Unfortunately, there was no survival or benefit to the addition of atezo with SBRT. But interestingly, as I've shown you multiple times in this small talk, we've shown that local control is one of the highest with SBRT, but actually when they added atezo plus SBRT, local control was worse. And here, what was felt in the talk at ASCO was that there was a potential overinterpretation of radiation changes post-treatment, but this is currently under review and would require further central review of the post-treatment imaging. We also are anxiously awaiting the results of Pacific-4. In contrast to many of the other studies, this adds 2 years of immunotherapy after SBRT. Getting back to our case presentation, now that you've learned a little bit about SBRT, I'd like a show of hands if anybody wants to vote on this case again. So we have 54 gray and 3 fractions. Any takers? Do you remember the case? All right, 50 gray and 5 fractions, Henning. That was what I treated the patient with, 60 gray and 8. All right. Yeah, I think any 2 to 4 are really acceptable in this case. And that was our treatment plan. And in summary, for high-risk SBRT cases, I would look at patient factors very closely and obviously work within your multidisciplinary tumor board to select patients appropriately for SBRT, but dose escalation may be important in squamous cell carcinomas. We know there are important clinical features such as ultracentral and central tumors that need to be approached with consideration of the tracheobronchial tree and other organs at risk, as well as total tumor dose. And biologic features such as the continued understanding of biologic predictors of recurrence, including ctDNA, could guide the use of more intensive therapies and use them more judiciously. Thank you very, very much.